is lens quiz discussion. So are you ready for the discussion? Yesterday's quiz was actually kind of easy, no? All right, so shall we start the discussion? Are people joining us? Okay, so the first question is, who's joined us? All right, Akshay. All right, very good. So, type of cataract seen in Fuchs uveitis syndrome. Okay, so the simple thing that you need to remember for this answering this question, I'll tell you at the end of this question. Okay, very simple thing. So, the type of cataract seen in Fuchs uveitis syndrome, and you think it's so difficult, and you're looking at the options. Posterior polar cataract, option B, anterior subcapsular, anterior polar, posterior subcapsular. So they've given you a mixture of options between polar, anterior and posterior, and subcapsular, anterior and posterior. See, when we talk about Fuchs uveitis syndrome, it is complicated by one, cataract and glaucoma, right? Now, whenever there is a cataract following a uveitis, it is a complicated cataract. And what is the location of a complicated cataract? Yes, complicated cataract is always a posterior subcapsular cataract. Most of the times, okay, very rare exceptions. So, in general, it is a posterior subcapsular cataract. So, the type of cataract seen in Fuchs uveitis syndrome is also going to be posterior subcapsular cataract. Yes. Now, if I ask you the same thing for the cataract seen in a child after who is having juvenile idiopathic arthritis, JIA, again, it would be a complicated cataract, which is a posterior subcapsular cataract. Okay, is that clear? Okay, so now we'll go to the next question. The laser used to manage after cataract. Okay, the laser used to manage after cataract. What is after cataract? After cataract is your posterior capsular opacification, PCO, that occurs after cataract surgery. It's a slow, progressive, painless decrease in vision, just like cataract. Okay, just like cataract. So that is why we call it after cataract, because normally we assure to the patients, we tell them you're going to have a great vision after cataract surgery, and a few months after cataract surgery, normally after a month or 3 months, it sets in. And then when the patient comes back and says, okay, what happened? They say, फिर से cataract हो गया. Again, you got cataract, jali हो गया. Okay. So it's an after cataract, also called as your posterior capsular opacification. So what is the laser that you use to manage it? First of all, what is the management for PCO? What is the management for after cataract? On the posterior capsule, we're going to make a small opening. Okay, so we're going to make a posterior capsulotomy, yeah, using a laser. Now, this laser has to have a photo-disruptive property. Okay, it has to have a photo-disruptive property. Now, let's take a look at the options. So, one is ND-YAG laser, another is double frequency ND-YAG laser, another is argon green, and Exima. See, argon green is a photocoagulative laser. It will heat the tissue and coagulate it. Okay, so no use. Exima laser is an ablative laser. It's like cutting. Okay, ablasive laser. So ablative laser, so not Exima laser. Double frequency ND-YAG is a photocoagulative laser. It's ND-YAG, which is the photo-disruptive laser. Yes, very good. It is treated with ND-YAG laser. Very good, BU. Wavelength is 1064 nanometer. Correct. Very good. Very good. So proud of you. So the laser used to manage after cataract, it is ND-YAG laser, which is a photo-disruptive laser with a wavelength of 1064 nanometer. Is that clear? Okay. So we'll move to the next question. Lens is an embryological derivative of. So we finally got one embryology question. So lens, see, I've told you surface ectoderm S5. Okay, S5. So only 5 structures in the eye that develop from surface ectoderm, which are 3 L's. LA, lacrimal apparatus, L-E lens, L-E-N-S, lens, L-I lids, and the glands present in the lids. 3 L's, okay? And 2 EC, 2 EC. What is this 2 EC? Epithelium of cornea, epithelium of conjunctiva. So LA lacrimal apparatus, LE lens, LI lids, EC epithelium of conjunctiva, epithelium of cornea. These are only 5 structures that are derived from surface ectoderm. Yes. Merry Christmas, Vicky. Merry Christmas. Hey, Merry Christmas to all of you. Yeah, I was just so serious about, discussing the questions. I just forgot because at work we don't have Christmas, nothing. Everything is a work day. All right. And one more thing. Endoderm, there is no contribution to eye at all. Eye structures, none from endoderm. Is that clear? Okay. Now next question, what is the direction of displacement of lens in case of ectopia lentis in Weil-Marchesani syndrome? What is ectopia lentis? Displacement of the lens. Now in Weil-Marchesani syndrome, what is the direction of displacement? It's very, very simple. You march forward. Yes, Weil-Marchesani. I'll tell you a trick. Okay, when you march, mostly we march forward. None of the countries march past. They march backward. Yeah. So march forward. So forward dislocation, anterior dislocation. Is that easy? Weil-Marchesani or Weil-Marchesani syndrome. What is the direction of displacement of the lens? It is anterior displacement of the lens. All right. Okay. Merry Christmas, all of you. Very good. Merry Christmas. Now, for Marfan syndrome, the direction of displacement is superior-temporal. Okay. And homocystinuria, it is homocystine. I-N is there. Cystine. Okay. So, infero-nasal, right? Exactly opposite to Marfan's syndrome. All right. Very good. Yes. So, BU, did you watch the... discussion? Yes, I had uploaded a little late yesterday, but yes, Vinod, very good. Correct. All right. Now, let's move to the next question. A 55-year-old patient presents with redness and sudden decrease in vision 1 month after cataract surgery. Yeah. What is the most likely diagnosis? So, patient has undergone a cataract surgery. 1 month later, he comes with a sudden decrease in vision. See, they've not told us whether it is painful or painless. Okay. Let's look at the options. Staph epidermidis endophthalmitis, Propionibacterium acnes endophthalmitis, after cataract, TASS. Now, what is TASS? Toxic anterior segment syndrome, which occurs within the first 24 hours or maximum first 48 hours after cataract surgery. So, this patient is presenting 1 month later. So, TASS is out. Yeah. And after cataract, does it ever present with a sudden decrease in vision? No, it's a slow, progressive, painless decrease in vision. Yes or no? So again, after cataract is ruled out. Now, this is a little tricky because when I taught you end off, see, there are certain standard textbooks which describe early onset end off as within 4 weeks of cataract surgery. There are some standard textbooks which describe as 6 weeks. Okay. So there is a 4-week cutoff, 6-week cutoff for end off to call it early and delayed. And we've got 2 options now. Staph epidermidis, which is the most common cause of early onset, and P. acnes, which is the most common cause of delayed onset. Okay. So we will always take that higher cutoff, 6 weeks. Okay. To be fair to our clinical practice. So, so this patient presents 1 month later, which would come under early onset end off. So what is the most common cause of early onset end of? Early onset end of is staph epidermidis. So this patient, a 55-year-old patient, presents with redness and sudden decrease in vision 1 month after cataract surgery. What is the most likely diagnosis? It is staph epidermidis endophthalmitis. Yes? Clear? Alright, very good. How a lens in, in Lowe syndrome, we have two lens findings. One that is very common that you all know is a posterior lenticonus that can occur. Okay, posterior lenticonus in Lowe syndrome. It can also be associated with a congenital cataract, Lowe syndrome. Okay, a congenital cataract, which is like a thin sheet, the cataract will be like a thin sheet. Alright, now the next question, hamarlopia may be experienced by a patient with. What is hamarlopia? Hamarlopia means day blindness or decrease in vision in bright light. So when there is bright light, the patient sees way lesser, and in dim light, he sees better. Why is that? Any centrally located opacity in the visual axis, if there is any centrally located significantly sized opacity, that can cause hamarlopia. Now let's see. Option A, punctate cataract. See, punctate cataract is your blue dot cataract. I've showed you it's more peripheral. It is not in the visual axis itself. And even if there are 1 or 2 dots in the visual axis, not significant enough to block the light rays. Yeah. Because in bright light, what happens? The pupil will myose. Bright light, there's physiological meiosis. So if I have a centrally located opacity, when my pupil undergoes constriction, it's going to block all the light. Yes. So that is why you're going to have decreased vision in bright light and a better vision in dim light in centrally located opacities. Now, blue dot cataract is not that significant. It's not that big in the center. So, not really, it's not a cause of hamarlopia. Cupuliform cataract. Yes, cupuliform cataract is a posterior cortical cataract and it is quite significant. It's huge. Yes. And that, yes, it causes hamarlopia. Let's see if there's any other option. Nuclear cataract. Nuclear cataract, yes, it is in the center. Nucleus is in the center. But it does not cause hamarlopia. It's not that, does not cause. Overall, it will decrease the vision. Okay. Cuneiform cataract. Cuneiform cataract are peripheral wedges. They are more at the equator, starting from the equator. Again, not a cause of hamarlopia. Yeah. All right. Next question, the equatorial diameter of the lens. So what is the equatorial diameter of the lens? Option A, 6 millimeter. Option B, 5 millimeter. Option C, 9 millimeter. Option D, 12 millimeter. See, on an average, it is 8.8 to 9.2 millimeter. That's what Parsons says. Okay. So 8.8 to 9.2. So we take an average 9 millimeter. So the adult lens, the equatorial diameter is 9 millimeter. Is that clear? So when you look at the lens from the front, it is like a circle, no? So that equatorial diameter is 9 millimeter. A 55-year-old executive with history of type 2 diabetes is diagnosed of significant nuclear sclerosis. So he's got nuclear cataract. He wishes to resume his office activities at the earliest. Okay. Which of the following procedures would you advise for this patient? So basically, what are we trying to ask? We are trying to ask which has the quickest or the fastest visual rehabilitation. Which of the following cataract surgeries? Option A, ICCE, intracapsular cataract extraction. Option B, ECCE, extracapsular cataract extraction. Option C, SICS, small incision cataract surgery. Option D, phacoemulsification. Which of the following is the answer? Oh, yeah, we had actually, I had given you FLACS. FLACS, that is femtosecond laser assisted cataract surgery. See, both phacoemulsification and FLACS, femtosecond laser assisted cataract surgery, they have a fantastic, very quick visual rehabilitation. So the patient can get operated and even go and start work. I mean, if it's just an office job, he can start in 2-3 days. Okay, just start, keep putting his post-op drops, but he can, you know, if he's that bent on his work and he's not getting chutti, you know, not getting leave like all of us. No, you can. At least you can say, I can work from home. All right. So if he wants to resume duties as early as possible, then it is FLACS. Please, bosses who might watch this video and go and show their employees or your Doctors, young doctors. See, this lady said you can go and work the next day, so no chutti. No, it's not like that. I'm just saying it's as quick a recovery as possible is with phaco and flax. Okay. Next, anterior lenticonus is seen in. Yes, anterior lenticonus is seen in. What is the answer? Yes, yes. Anterior lenticonus is seen in. What is the answer, guys? Yes, Alport syndrome. Very good, Binod. Very good, Binod. Very good. So, Alport syndrome, anterior lenticonus. Posterior lenticonus, Lowe's syndrome. Yes, very good, BU. Good. The dye used to stain anterior capsule of lens. Why should you stain anterior capsule of lens, and for which step do we do it? For capsulotomy, anterior capsulotomy, whether you're doing a can opener technique or a CCC, continuous curvilinear capsulorhexis, depending. If you're not able to get a proper visualization, especially in case of very mature cataracts or hyper mature cataracts, where you want to stain it. Because against the fundal glow, you'll be able to see beautifully without the dye. But yes, when you have a white cataract, then it's difficult to visualize. So in that case, we want to stain it. So that is trypan blue. Yes, that is trypan blue. Is that clear? So this is a PYQ as well. This is a previous year question. So it is trypan blue. What were the other options? Lissamine green. Guys, lissamine green is for conjunctiva, to stain the conjunctiva for dry eye. Fluorescein stains the epithelial defects on the cornea, and it can be used for angiography to visualize the retinal vessels. And rose bengal is for your mucin, for dry eye rose bengal. And what is the other one? Yeah, the answer was trypan blue. Any doubts, bache, in this? Okay. Any doubts? Any doubts, guys? Let's. So today we are going to have a quiz on uvea. Yes. So today's quiz uvea, and tomorrow 11 a.m. we'll have discussion of the uvea questions. And there is a test and discussion going on in the EyeMentor app. And regarding the Christmas discounts, you all know. So you can download the app. I've given you the description in the... Oh, you watched, huh? Okay, okay. Good, BU. Very nice. But yeah, very good. Romba super. Okay. So download the EyeMentor app. I've given it to you in the video description. Okay. And yeah, guys, I'll see you all tomorrow at 11. All right. Okay. Good, BU. See you tomorrow.